Well, it's a pleasure to be speaking with you again to provide this update on COVID-19 therapeutics for March 2022. Here are my disclosures. Today, I'll be covering several topics. An update on Molnupiravir from the recent CROI conference, recently published data on Nirmatrelvir and ritonavir, another CROI update, this time on Bebtelovimab, and breaking data on Bebtelovimab, the newest monoclonal antibody to receive emergency use authorization in the United States. Let's start with Molnupiravir. As you may recall from prior presentations, this is an oral prodrug of N-hydroxycytidine, the pathway for metabolism shown here on the slide. N-hydroxycytidine triphosphate is a substrate for the SARS-CoV-2 RNA-dependent RNA polymerase. It's unclear whether this drug actually functions as a polymerase inhibitor, but is incorporated into the copied RNA, producing numerous errors that eventually impair SARS-CoV-2 replication. Data that we saw several months ago that led to the emergency use authorization of Molnupiravir demonstrated a significant reduction, about a 50% reduction in the risk of hospitalization among outpatients with symptomatic COVID-19 who were at high risk for developing severe COVID-19. That was at the interim analysis. And surprisingly, when the final full analysis was performed, the impact of Molnupiravir was substantially reduced to just about a 30% reduction in risk of hospitalization or death. At CROI, we saw a presentation of another phase 3 study presented by Dr. Kumarasamy from Chennai in India. This study enrolled adults ages 18 to 60 who had mild COVID-19. They had to have symptomatic disease with a positive test for SARS-CoV-2 that was 2 days old or less, and their symptoms could only have been 5 days or less. They were randomized in an open label manner to receive either 800 milligrams twice daily of Molnupiravir or standard of care, and the drug was administered for 5 days. Primary endpoint, similar to that of the study we just referred to, was the rate of hospitalization from the time of randomization, but here through day 14 of follow-up, with secondary endpoints including clinical improvement, overall mortality, viral clearance, and treatment-emergent adverse events. The study was conducted at 23 sites, all in India, and ultimately recruited 1,200 participants. Here you see the primary endpoint, the hospitalizations through day 14. And there was a substantial reduction, here really about a 75% reduction in the rates of hospitalization. You can see about 1.5% of the Molnupiravir recipients versus about 4.25% of the standard of care participants progressed to need hospitalization. And this difference was highly statistically significant. Looking at the secondary endpoint, the proportion of participants with clinical improvement, we see that at days 5 and day 10, there were highly significant differences favoring Molnupiravir. The difference remains significant at day 14, although I have to say that 3 percentage point difference doesn't seem very clinically significant. If we look at time to clinical improvement, we see here in this Kaplan-Meier plot, once again, there is a highly statistically significant faster time to clinical improvement, with median time to improvement in the Molnupiravir group being 6 days as compared to 10 days in the standard of care group. Turning to treatment-emergent adverse events, there were similar rates of headache, but there was somewhat more nausea, diarrhea, and overall any treatment-emergent adverse events among the Molnupiravir recipients compared to the standard of care, but the vast majority of these were not serious adverse events. Well, let's turn to an update on Nirmatrelvir and ritonavir. Nirmatrelvir is an inhibitor of the main protease of SARS-CoV-2, which is necessary for processing of SARS-CoV-2 proteins during viral assembly and maturation. It needs to be co-administered with ritonavir in order to achieve and sustain adequate levels to be inhibitory of SARS-CoV-2 in infected persons. We previously saw top-line results of the phase 3 trial that led to the emergency use authorization of this combination for treatment of symptomatic COVID-19 in outpatients at high risk of progression to severe disease. But these data have now been published in the New England Journal of Medicine and are summarized on this slide here. If we look at outcomes according to the time since onset of COVID-19 symptoms, we see that for those who were treated within 3 days of symptom onset, that there was a substantial reduction in the percentage of participants who had progression to hospitalization or death, going from 6.5% in the placebo group to just 0.7% in the treated group. And then for those who were treated within 5 days of symptom onset, actually quite similar results, 6.4% in the placebo group and 0.8% in the Nirmatrelvir ritonavir group, essentially a 90 to 95% reduction. Looking at this from the perspective of progression to hospitalization or death from any cause through day 28, here in the Kaplan-Meier plot, you can see again a substantial difference with about 6 to 7% in the placebo group and just under 1% in the treated group having progression over those 28 days. In the subgroup analysis, with the exception of those who had also received or subsequently received COVID-19 monoclonal antibody treatment, Nirmatrelvir plus ritonavir was favored in all of the subgroups. So regardless of duration of symptoms, regardless of age, gender, body mass index, presence or absence of diabetes, and also baseline SARS-CoV-2 serostatus, although the magnitude of the benefits seemed somewhat less among those who were already SARS-CoV-2 positive, perhaps an indication of duration of disease. Let's turn now to additional news of Sotrovimab. This is a monoclonal antibody directed against the spike protein. It is one of the monoclonals that remains active against the Omicron variant. So this is a monoclonal isolated from a survivor actually of SARS-CoV-1 infection with cross activity against SARS-CoV-2 that targets a conserved glycan position at position 343 in the spike protein. It also carries the LS modification of the Fc domain that leads to a substantially prolonged half-life for this antibody. We had previously seen both the published data and then the full data set for COMET-ICE, the phase 3 trial that led to emergency use authorization of Sotrovimab, demonstrating an 80% reduction in the risk of disease progression for symptomatic outpatients at high risk for severe COVID-19. What were presented at the CROI meeting were results from the COMET-TAIL study. We've seen high-level results of this, but now here are the full data that were presented. COMET-TAIL was a 3-arm study that compared the authorized dose of Sotrovimab administered intravenously to 2 different doses of Sotrovimab administered intramuscularly. The advantage of, or potential advantage of intramuscular administration is that it logistically is much more feasible to administer than doing infusion therapy. So this study enrolled participants who were 12 years of age or older at high risk of progression. Here on the slide are the various categories of risk. The primary endpoint at day 29 was hospitalization for more than 24 hours for the acute management of illness or death due to any cause. Now, unique to this study is that it was set up as a non-inferiority study with incredibly tight margins, so that the upper bound of the confidence limit had to be 3.5% or less in order to achieve non-inferiority of the intramuscular injection as compared to the intravenous injection. Enrollment occurred primarily during June through August of last year during the Delta variant surge. So even though we know that in the laboratory, the sotrovimab is effective against the Omicron variant, it's important to keep in mind that this study was not done during the Omicron surge, but during the Delta surge. Now, early on, this 250 milligram dose was found to be inferior at an interim analysis and was therefore discontinued. And so what we had presented at CROI were the data comparing the 500 milligram IM dose to the standard intravenous dose. This slide shows the primary endpoint analysis. This is based on roughly 750 participants or so. And what you can see is that the risk difference between the intravenous and intramuscular formulations or administration was just 1%. And this met the non-inferiority standard, the upper bound of the confidence limit being 3.4, which is just below the 3.5 set as the margin for non-inferiority. In terms of absolute numbers, what you can see is that there were approximately half the number of people in the IV group as in the IM group, but these are still small numbers. And so it's roughly 2.5% versus 1.5%. And that's how this risk difference eventually gets calculated. Looking at injection site reactions from those who received intramuscular administration, there were expected injection site reactions of pain and tenderness at the site, as well as some induration and swelling. With one exception, these were all grade 1 and grade 2, and all resolved within a few days. If we look at an additional analysis that was presented of the COMET-ICE study, that phase 3 trial I mentioned a few slides ago that had been published in the New England Journal of Medicine. Here we saw an additional analysis that parsed the results of that trial based on serostatus. That is, at the time that the participants received either sotrovimab or placebo, did they already have their own antibody against SARS-CoV-2? The vast majority of the participants were seronegative because people were enrolled within a few days of testing positive for SARS-CoV-2 or developing symptoms of COVID-19. But about 200 participants were seropositive, roughly even numbers in the placebo and sotrovimab group. You can see there was still some benefit of sotrovimab, roughly half the number of hospitalizations or deaths. There are no deaths at all, so it's really all hospitalization. But because of the tiny numbers, this doesn't achieve statistical significance. In the seronegative group, we continue to see about an 85% reduction in risk of disease progression, and that remained statistically significant. Lastly, let me turn to Bebtelovimab. This is the most recent monoclonal antibody to be authorized for use. This study was known as BLAZE-4. We only have the top-line results from the prescribing information and the fact sheet for healthcare providers as part of the emergency use authorization. The study really depended entirely on the virologic effect of Bebtelovimab, showing more rapid clearance at day 5 compared to placebo. That was true for Bebtelovimab given by itself, shown in red, or in combination with bamlanivimab and etesevimab, 2 monoclonal antibodies previously authorized for use, but no longer in use because neither one of those antibodies is active against Omicron and have limited activity against Delta. Bebtelovimab does neutralize Omicron. You can see in this table here the activity against a range of variants. So here in this row, we see the main Omicron variant, and then the additional variants, BA.1.1 and BA.2, and there is no significant change in vitro neutralization. Here showing data for pseudotyped viruses, very similar results are seen using actual SARS-CoV-2. I should say no change, as you'll see in the footnote, means a less than 5-fold shift in susceptibility. So it doesn't mean that there's no change in IC50 at all, just no change believed to be of clinical significance. Well, it so often happens in this fast-moving field. No sooner did I finish recording my talk for this update than new information became available about sotrovimab, which we're adding on to my brief discussion. Recently, data coming from Vir has shown that the Omicron BA.2 variant is less susceptible to neutralization by sotrovimab than the original Omicron variant, BA.1.1, or the BA.1 variant. And you can see here that BA.2 has about a 16-fold increase in IC50 compared to the other Omicron variants. Now, 16-fold wouldn't be so terrible because the IC90 for sotrovimab is about 160 or so nanograms per mil, and so 16 times greater than that would get you into the 4 microgram range, which is still well below the 40 microgram trough concentration. However, other information coming from Nat Landau's laboratory in New York City using pseudotyped lentiviruses expressing the SARS-CoV-2 protein showed a much greater resistance of the Omicron BA.2 variant compared to the Delta or the original isolate. You can see here these red squares represent the BA.2 variant. And here, even at concentrations of 10 micrograms per mil, you're not even getting to 50% inhibition, with an estimated IC50 of about 48 micrograms per mil, which would really be well above the trough concentrations achievable by infusion of the antibody. As a consequence, just 2 days ago, the US FDA issued a revised emergency use authorization in which they limited the authorization of sotrovimab, stating that sotrovimab is not authorized for treatment of mild to moderate COVID-19 in geographic regions where infection is likely to be caused by a non-susceptible SARS-CoV-2 variant. Well, what does likely to be caused mean? Typically, that's when a variant represents 80% or more of the isolates in a region. If we look at the distribution of isolates from sentinel surveillance sequencing in the United States, what we see here, the orange represent the Delta viruses, and then the various shades of purple are the Omicron isolates. And of course, over the course of the winter, we saw the Omicron surge take over and displace Delta. And now, even though cases are rapidly diminishing in the United States, there has been this gradual rise in the light purple or pinkish color here at the very bottom of the BA.2 variant. This now represents somewhere between 3 to 5% of isolates in the United States. Actually, in my region in Massachusetts, it's up to about 8%. So we'll have to keep an eye on that, and it just shows you how rapidly things can change in this field. So thank you for your attention, and I look forward to the question and answer period.